David, thank you. Arnold, thank you. I'm grateful to all of you for your most kind hospitality that you and others have shown me here in Louisville. I think I've mentioned to you it's been 20 years since my last visit, and it's been a thing of beauty to see the transformation in this wonderful city. And David, it's been beautiful to see what's gone on here in bioethics under your leadership and what's happened. And it's a special pleasure and privilege for me to be the inaugural lecturer, the Cheng Lectureship. This is a special privilege. I've learned that Dr. Cheng is truly a special person. I admit it was not my pleasure to meet him when he was with us, but what I've learned, he was truly a special person. The world is a better place because of him, and it's so appropriate because he walked the walk, not just talked the talk. He made ethics a living reality. And the family has given me permission. I've learned he had a good sense of humor to show how ethics is something that we translate into day-to-day reality. And his wife and his family have given me permission to relate a story that happened a few years ago. That when they were building their house, one day he was working hard in the backyard, working so hard, making the patio in the backyard all by himself. And he was struggling hard. The whole family was away. And he was working hard, getting the cement perfect in the backyard. And he was working hard. He was working like a dog, working so hard, getting it perfect. And at the end of this grueling day, he went upstairs to take a shower. And what do you think happened? As he was taking a shower in the house, he looked out the window and he saw children playing in the patio, destroying the cement, making a mess. And Dr. Cheng, who I learned was a very compassionate, kind, reserved man, did something that he never did. He lost his temper. He got furious. He ran down the steps, threw a towel around himself, started throwing stones at the children, did something he never did. He started cursing at the children. He got furious because his hard work was being destroyed. His hard work, his cement was being destroyed. And fortunately, his lovely wife, Malvina, comes home at that time, pulls him into the house and says, "Honey, Sam, what's going on here? You're a doctor. You've dedicated your life to patients. You dedicated your life to children. How could you do this? I've never seen you like this." Sure enough, Dr. Cheng gets his composure, goes inside the house and said, "Yes, Malvina, I love children in the abstract, not in the concrete." Now, there's an important message to be learned here. Many of us like ethics. We think we're ethical people. The real challenge for us is, like Dr. Cheng did with his professional life, is to love ethics in the concrete, day-to-day reality, not just in the abstract. And in the presentation I want to give today, as David said, I work hand in hand with Larry McCullough, who's a philosopher, someone that I met a quarter of a century ago. And this is work that we've done over a quarter of a century. My daytime job, I'm an obstetrician. And this is work that we've done over a quarter of a century with concrete clinical reality. And what I'd like to do, it'd be impossible to discuss everything, but my core interest is obstetric ultrasound. In the few minutes we have today is give you an overview and to capsulize our view of what obstetric ethics is, capsulize the important concept, the ethical concept of the fetus as patient, discuss briefly some options before fetal viability and after fetal viability, a few words about the evolving role of fetal research, and time permitting, ultrasound and patient autonomy with two important counterexamples. We all know about morality, right and wrong behavior, good and bad character. Bioethics is the disciplined study of morality, physicians, patients, institutions of healthcare, and healthcare policy that affects all that we do. And it's so important that we have leaders such as David Dukas here at Louisville to move this important discipline forward. If we look at clinical practice, it's derived from both science and ethics, and when we have one without the other, it's doomed to failure. Now here's the rub. When there's scientific disagreements, data sets are collected, and we have statistical methods of analysis. With ethics, this is not adjudicated by data sets, it's adjudicated by ethical argument, and indeed, there are criteria that define good arguments from weak ones. Ethical analysis and ethical argument are the material and methods of how normative ethics works. And we'll give some examples in a few moments. Ethics supersedes the law. This is a radical concept for my target audience, obstetrics. I think many of you know that the professional liability crisis is something that threatens obstetrics throughout the country, especially in my home state of New York. I, as chairman of a department of obstetrics and gynecology, must pay $220,000 for every one of my doctors to practice obstetrics. Indeed, that supersedes salaries. But I make a bold claim that ethics is more important than medical legal considerations. It's unethical for a doctor to consider that I'm going to do a cesarean delivery for a breech presentation because he or she wants to avoid medical legal liability. It's very ethical to say, I want to do a cesarean delivery because it's safer for the fetal patient. I don't want to play games with you. I'm involved in many, many legitimate ethical risk reduction strategies. Where it crosses the line is where the doctor's interest is placed ahead of the patient's interest. And indeed, I'm sure this is a concept Dr. Cheng would support very, very strongly. Religious belief. This is something we went into some detail this morning at OBGYN Grand Rounds. I may have a religious belief. You may or may not have a religious belief. I'm not speaking against religion, but we need an ethics that pertains to all of us, that doesn't demand a particular religious belief, an ethics that respects all religious belief in absence of religious belief. Professional consensus and appeals to authority. Some authoritative statements, whether they be from our College of Obstetrics and Gynecology, the AMA Board of Trustees, or different authoritative bodies may be good, some may not be so good. And through the years, this has been shown. One secular ethical principle I think everyone in this room knows, primum non nocere. But what Larry has taught me, this ancient dogma, is really a Latin misinterpretation from the Greek. What a better translation of the Hippocratic writings is at least do no harm, and the secular ethical principle of beneficence much better captures the Hippocratic writings. There's nothing holy, no benediction here. This simply means to do good for our patient. Beneficence means to assess objectively various options and to implement those that protect and promote the interest of the patient by securing for the patient the greatest balance of goods over harms. A lot of words. Sir William Osler says it better than I could. The art of medicine lies in balancing probabilities. And this morning when we spoke to the Department of OBGYN, indeed the goal of residency training programs is to teach doctors how to better balance in different medical circumstances. A big change in the past 20 years since I've last been to Louisville, and a very welcome change, not just in obstetrics and medicine and in all fields of medicine and surgery, is the greater reliance on evidence in how we make decisions. An important counterbalance to beneficence or medical judgment is respect for the patient's autonomy. Respect for autonomy accepts that the patient has a perspective on her interest that is based on her values and beliefs, and the patient should have the freedom to choose alternatives based on these values and beliefs. The informed consent process is how we operationalize respect for autonomy. And this means very succinctly, we disclose information, the patient understands the information, and a voluntary decision is made by the patient. Another important ethical principle, and one that we spoke about last night when we spoke about developing countries throughout the world, is the principle of fairness or justice. It's both substantive and procedural in its nature. An important concept is the concept of prima facie obligations. We need to balance these competing obligations in different clinical circumstances, and indeed, during the past quarter century, we've written about a myriad of topics, how we sometimes do the delicate balancing. And indeed, at OBGYN Grand Rounds today, we spoke about the sometimes delicate balancing that occurs. One more abstract ethical concept that we need to address before we move on to some concrete clinical realities is the concept of the fetus as patient. What makes the challenge in obstetrics so fascinating is that sometimes we do have two patients, and we must balance maternal and fetal interest. And a core challenge is, when do we as doctors have obligations to the fetus as a patient? Traditionally, this has been addressed in terms of fetal rights, fetal personhood, a fetal soul, or the categorical denial of fetal rights. The woman has control and the fetus is merely part of the woman's body. In the extreme positions, you know. Now, what Larry has taught me, these extreme positions have gone on since the time of the ancient Greeks. I think many of you know about the prescription against abortion in the Hippocratic Oath. The Pythagoreans took the opposite point of view. And these debates have gone on for 2,500 years, and they can go on for another 2,500 years. I suggest we put it aside. If you have your point of view on this subject, I don't try to dissuade you. Let's leave it aside and start somewhere else. If we accept that the child is a patient, when there are clear linkages between the fetus and the child the fetus will become, we have obligations to the fetus as a patient. Prior to fetal viability, all of our technology is worth naught without the woman's body as a necessary condition. After viability, medicine has a social role interest because much can be done. What's the rub with fetal viability? Is that there's no sharp red line. As we described this morning, the fact that there's no uniform definition of viability doesn't disable it. Viability doesn't just apply to this in obstetrics, it applies to me if I have acute appendicitis. Viability for me here in Louisville, if I have acute appendicitis, is very different for the concept of viability with me in sub-Saharan Africa with acute appendicitis. It's about 24 weeks, and again, we've dissected the literature and written about the subject. Even for the pre-viable fetus, even for the in vitro embryo, if the woman has established that linkage between fetus and the child the fetus can become, we have obligations to the fetus as a patient. What we're arguing for is, let's get away from debates about fetal versus maternal rights. These get us nowhere. Rather, let's look for a clinically relevant balancing of ethical obligations by dissecting obligations to the fetal, patient, and pregnant woman. When the fetus is a patient and the evidence is conclusive, counseling should be directive, sometimes in the form of a strong recommendation. So, if on leaving here, an obstetrician goes to labor and delivery, and there's acute fetal distress, the appropriate action is a recommendation, sometimes a strong recommendation, for cesarean delivery. It's a misread of ethics that all of counseling is non-directive. For example, if I leave here, God forbid I have acute appendicitis, I hope the surgeon is going to be strongly directive for surgery. Where recommendations are ethically justified is when medicine is competent to do so. Likewise, when the fetus is a patient, even for a pre-viable fetus, let's say a 10-week embryo, and the mother is continuing the pregnancy, if the woman is abusing alcohol, it's appropriate for the doctor to counsel her strongly to minimize her stop to use alcohol. You see, this is where the language of rights sometimes obfuscates an obstetrician's obligations. Now, as we'll see in a minute, when the fetus is not a patient, when a fetal anomaly is diagnosed, non-directive counseling is appropriate, and we'll come to that now. Prior to fetal viability, aggressive management. And by aggressive management, I mean all of the tools that perinatal medicine has developed, especially in the past quarter century. John Queenan, a previous chair here, was one of the pioneers in perinatal medicine. He was one of the pioneers in ROGAM, one of the great breakthroughs in perinatal medicine. Intrauterine transfusion, indeed, he did some of his pioneering work first at my medical center at Cornell, and then he came here to Louisville to be the chair not too many years ago, and did some of his pioneering work right here at Louisville when he was chairman. So aggressive management, there's much that perinatal medicine, both on obstetrics and I must admit more so on the neonatal side, with what neonatology has done during the past quarter century to improve the status of both the fetus and the neonate as patients. So I want to emphasize that point by aggressive management. But we need to talk for a few minutes about abortion. We spent the whole hour about this in OBGYN grand rounds today. This is the important point. The decision to abort because of fetal anomaly is only in part governed by health-related issues. It's amazing to me when with each group of third-year medical students at Cornell, when I ask them, when I speak to the different them in rotation, I say, let's say I diagnose hydrocephalus or spina bifida at 18 weeks. What goes into a woman's decision to keep or abort a pregnancy? I get answers like quality of life, how certain are you of the diagnosis, and usually, not usually, often, they forget some basic issues, whether she is willing to rear a handicapped child, whether she can afford the expense, whether abortion is consistent with her religious beliefs, which is so fundamental. And medical students, I'm ashamed to say obstetricians, often forget this. This past summer I was at a convention of Down syndrome parents, and several represented to me that they believe that their obstetricians push them into abortion if a Down syndrome was diagnosed in utero. And I argue strongly this is inappropriate. A doctor's role is to present information, not to steer them one way or the other. For example, let's take lumbosacral spina bifida. Some women may look at this data and say, my God, this is horrible. A lot of these babies die. A lot can't walk. A lot have bad outcomes. Others may look at this and say, wait a minute, this isn't so bad. Most of these babies live. So what if they can't walk? That they can walk with braces. Most have good IQs. The point I reiterate over and over, and I can't emphasize enough, Medicine in general, the obstetrician in specific, is not competent to make the decision for the woman whether to keep or abort the pregnancy. It's a matter of medicine incompetence. Therefore, recommendation should not be given in this regard. And I can't emphasize this point emphatically enough. If I emphasize, it's only because I see what I consider clinical errors made over and over, where doctors try to push patients one way or the other. With this abortion issue, we could spend time with selective reduction, fetal reduction, but I want to spend more time on this because I think this is the more important issue. The distinction between professional ethics and private conscience. And I think most of you were not there this morning, and this is a critical distinction. I argue strongly that it is totally appropriate for a doctor, and if I say doctor, this is the group of my target audience, so I speak through not just in this country, but throughout the world, is totally appropriate that a doctor not perform abortions either in training or in practice based on a well-founded religious belief, and I argue that strongly. However, what is essential is that he or she not try to steer women one way or the other. And we've written about this a few months ago in the American Journal of Obstetrics and Gynecology. He or she not try to obstruct the referral. We made the distinction between a direct and indirect referral. It's not essential to pick up the phone and make a direct referral to a doctor who does the abortion. The minimum professional standard is to make it clear to the patient where it could be done, such as Planned Parenthood or the Department of Obstetrics and Gynecology at the University Center, so that the patient is steered away from practices who would do this inappropriately. This distinction between professional ethics and private conscience is an important one. If this isn't controversial enough, the issues after viability are even more controversial. Aggressive management, again, is the ethical standard of care. There's much that we can do to improve outcome after viability. We can deliver in a tertiary center, such as the university hospital, with access to all of the interventions both before and especially after birth. But I want to spend a few moments on some options that are important. Third trimester abortion or feticide, cephalocentesis, and non-aggressive management. And I want to put this in an international context. This is work that I did with Stuart Campbell in Great Britain a few years ago that I think is important, and it'll set the stage for our discussion. A few years ago in Great Britain, the law was liberalized and basically permitted third trimester abortion. If I use the terms interchangeably, it's only because the language is confused. The way this is done is the potassium chloride is injected into the heart of a fetus in the third trimester, basically for any fetal anomaly. And some doctors in Great Britain and France would do this today. Most fetal anomalies involve incremental risk in morbidity and mortality. We would argue that this in and of itself does not justify a third trimester abortion. We would, and I'll make the argument in a moment. If we accept that a person is a human being with decision-making capacity, and a patient is a human being presented to a physician, and there exists beneficial interventions, the fact that a viable fetus is not a person, it does not follow that a viable fetus is not a patient. As a rule, aborting the third trimester fetal patient violates beneficence-based obligations to it. It's therefore, as a rule, ethically impermissible no matter what the law might permit. There is one well-established exception to this prohibition. And these are criteria we put forward in the New England Journal of Medicine 25 years ago, where there's certainty of correct diagnosis and certainty of a dismal outcome. Anencephaly, where there's absence of forebrain meets this definition because these infants succumb. We acted on this. This is when I was at Yale, when all fetuses were alive at the time of diagnosis. There were no maternal complications, and the parents elected termination of pregnancy. This was before feticide was even considered. Now, I show this slide only to illustrate, even for anencephaly, where death is certain, this is controversial. And it was argued that this is a particularly odorous chimera of a logic and humanity of medical hubris. As such, a civilized society is compelled to reject it summarily, making the point that even for anencephaly, this can be viewed to be controversial. We then liberalized this and argued that for certain anomalies such as trisomy 13, 18, renal agenesis, thanatophoric dysplasia, holoprosencephaly, if we're not dealing with certainties, we're dealing with near certainties, and hence an ethical justification could be made. I'm not saying to do it here. There are other macroethical issues that need to be factored into this. But here's the point. For Down syndrome, spina bifida, especially achondroplasia, where we're dealing with normal intelligence, I would argue strongly feticide should not be done in the 3rd trimester. And on this issue, I disagree strongly with some colleagues that I'm very close to in Great Britain, France, and some other countries in the world. And the argument goes that many anomalies involve burdens on patients, society, and institutions. We would argue these burdens are distinct from the doctor's obligation to protect and promote the fetal patient's interest. In theories of justice that emphasize equality of opportunity for human experience and development, the assumption of such burdens by society would be ethically obligatory. We would argue that society has a justice-based obligation to look after its disabled and maximize potential, so we disagree with those who would argue in countries such as the United States, Great Britain, and France that the seriousness of an anomaly should be defined, we would argue should not make reference to burdens on others. And hence, you see the thrust of our argument. We would argue that there should be limits on 3rd trimester feticide, and we would put forward Down syndrome, achondroplasia, as paradigm anomalies that this should not be performed for. Before we move on, I want to mention that at least one country where, forgive me, the Dutch Pediatric Society has taken it a step further with the Groningen Protocol. And this is an area where we've gone public, and please, I've debated this and we've written in the literature about this, where they actually, the Dutch Pediatric Society has advocated, not just advocated, they've put into practice active euthanasia, active killing of neonates with some forms of spina bifida. Fortunately, this has not been widespread to other countries. We've taken a strong stand against this, as some others have, and I think this is on the wane, but at the moment it's still on the books by the Dutch Pediatric Society. I mention this just to give you a flavor of some of the international debates that go on. This is not an issue in the United States. Let's move forward. As you can see, I'm trying to give you a flavor of the scope of some of the issues in perinatal medicine. There was the time, not too long ago, 100 years ago, when the mark of a great obstetrician was the ability to perform destructive procedures. Procedures such as the cranioclass, the basiotribe, the sickle knife, and sickle scissors. These were procedures that would dismember a fetus, because to perform a cesarean delivery would be a death sentence to a woman. These were before the days of antibiotics, before the days of blood banking. Anesthesia was primitive, and cesarean delivery would have at least a 50% mortality rate. As you know, these procedures are all part of ancient history. for good news. And they've all fallen by the wayside, with one interesting exception, cephalocentesis. And I mentioned this to David before. This was the topic that brought me to Larry McCullough 25 years ago. When you have a hydrocephalic head that's too big to pass through the birth canal, there's some variations on the theme, but you have essentially one of two choices. You can either do a cesarean delivery and lift it out intact, or aspirate so much fluid from the head that you can compress, and of course do it under ultrasound guidance. You can see the needle tip. The skull can collapse and hence pass through the vaginal canal. Titus took the view 70 years ago that this should always be done. And 70 years ago he was probably right, because we were dealing with a hopeless situation and hence spare the mother the cesarean. John Lorber from Great Britain did a classic work where he challenged this and said, wait a minute, not all extreme hydrocephalus is hopeless. And he did a landmark paper where he showed that even extreme hydrocephalus could do well, some with even superior intelligence. What changed this was before modern pediatric, not fetal surgery, please, fetal surgery has not had the success that diagnostic ultrasound has had. But before modern pediatric surgery, hydrocephalic heads would get bigger and bigger without good results. With the advent of pediatric surgery and the ability to perform ventriculoperitoneal shuntings, results got better and better. This is from Lorber's series. This is one from the University of Pennsylvania, and results got better. Clearly, what defines the outcome of hydrocephalus is not the degree of ventriculomegaly, but the underlying etiology. So you could have the most minimal ventriculomegaly, but if it's due to a destructive brain process, such as cytomegalovirus or toxoplasmosis, the results can be deadly. An extreme degree of ventriculomegaly, if relieved by shunt placement, you can have a good outcome. The other line of support that goes against routine cephalocentesis, it does damage. We've documented subdural hemorrhage due to cephalocentesis, subarachnoid hemorrhage due to cephalocentesis, intraventricular hemorrhage due to cephalocentesis. For these reasons, for isolated hydrocephalus, we recommend cesarean delivery. The reason for this is there's the potential for normal, even superior intelligence. It's sometimes impossible to predict which fetus will do well, and the potentially destructive nature of cephalocentesis. Now, if the woman wants cephalocentesis, this is not a case for coercion. We believe there's still an extremely, extremely rare role for coercion in modern obstetrics. The last time we did this was 15 years ago. Time permitting in the question and answer period we'll do this, but not in this case. And this, knock on wood, I've never been in a position to have done a cephalocentesis in this setting, but I would have do it is the least worst alternative, because we wouldn't want a ruptured uterus and risk both the maternal and fetal death in this setting. If we take hydrocephalus with, let's say, holoprosencephaly, here the recommendation would be for cephalocentesis, because we're dealing with the dismal situation and we want to avoid the long and short-term consequences of the vertical scar in the uterus. And we're dealing with a hopeless situation. Having said that, we've done at least 2 cesareans with holoprosencephaly. We do this more for maternal indication to help her with the grieving process. The woman wanted the baby born alive, and the psychosocial benefit to the woman would have value in the setting. One option that hasn't received the attention it deserves, and we've published this in Lancet, is non-aggressive management. And we believe that just because a woman doesn't want the option of abortion, when we're dealing with very high probabilities, there is a role not to do a cesarean for fetal distress, not to use our aggressive ultrasound surveillance. And in these settings, it makes sense. It's not a binomial. It makes sense not to do everything and to have a hands-off approach when we're dealing with severe fetal anomalies. Sometimes perinatologists are afraid. They're afraid if they don't do everything, there'll be medical legal risks. No, there's an important middle zone here. Let me move quickly with another area of fetal research. The history of unmanaged innovation, especially in the surgical subspecialties, has been uneven. Innovation should proceed according to accepted standards. We've written about preliminary investigation, the importance of equipoise leading to randomized clinical trials. Equipoise is a state of uncertainty about the relative clinical benefits and risk of competing clinical management strategies. Equipoise is what warrants a randomized clinical trial. Clinical equipoise is what's governed actions in the past. Better listed is opinion equipoise. Now, the relevant expert community is roughly divided. Lilford suggested when about 2/3 of the community is divided, and as a rule of thumb, this was proposed. Normative equipoise we put forward is a better concept today, and this is based on evidence. Larry and I work with NAFNIC, which is the North American, not free trade, but fetal therapy research group, and we put forward the current randomized study that's in practice now for open spina bifida. This is a study that we would argue is a very ethical study, that the scientific community is uncertain whether the benefits of open fetal surgery for spina bifida are on net balance good or harm, and we'd argue that normative equipoise is reached. Therefore, it's an ethical study to randomize. It's a slow study, it's a hard study to do, but this is the best way to get the answers to see whether or not open surgery is the appropriate standard of care for spina bifida in utero. And one last concept I want to put forward. Some transition that has happened during the past few years, and I think a very good transition, is the shift from a protective to a balanced approach in research efforts. And after World War II, and the horrors that went on in World War II, and what happened in America with the infamous Tuskegee experiments, there was a big move to protect vulnerable populations such as prisoners. And what more vulnerable population is there than fetal patients and the pregnant women who carry the patients? So there was a big move not to do research in women. But what's the problem if research is only done in men? If research is done with medications in men, what is the generalizability to women? So the NIH very appropriately said, wait a minute, we need a more balanced approach. And hence, there was a move for a more liberalization. The study I just described, a randomization of spina bifida repair in utero, 15 years ago could have never been done because there was a more protective approach. And I think this is something good that has happened in research ethics in perinatal medicine, a greater liberalization. Otherwise, the field would not have moved forward. 5 more minutes I have. Let me just move on to one more topic because it's an interesting one. Ultrasound and patient autonomy. Respect for autonomy plays a central role in the ethics of ultrasound. I want to give you 2 counterexamples. One where we would argue it's justifiably invoked, one where we'd argue not so much. We have been proponents of obstetric ultrasound as autonomy-enhancing strategies for pregnant women. 2 decades ago, in fact, I think when I was last here 20 years ago, I spoke about second trimester ultrasound as an autonomy-enhancing strategy. That was a hot topic 20 years ago, whether all women should have second trimester ultrasound so that they could learn about fetal anomalies, not to recommend abortion, but to give women options. More recently, we've written about first trimester ultrasound so women have access to this. Professional integrity is so important. And I can't emphasize this enough with ultrasound. I show this slide and I don't put the authors, it's not from America. No one in America would have the courage to publish this. These are false positive diagnoses. The greatest harm with ultrasound today is not bioeffects, but it's the false positive diagnosis. And if women are going to abort pregnancies that are perfectly normal. So understand, in this study, there was a 1 in 10 chance if this group called hydrocephalus, hydrocephalus wasn't there. And believe me, I've seen my share of false positive diagnoses in our unit. If this is going to happen, this is the ultimate disaster. And all the arguments for autonomy enhancement go out the window. So quality is essential. And quality goes forward. I put this slide up to show how the importance of autonomy enhancement. This is a beautiful study from Sweden about non-directive counseling, where 3 options were given the women. 1 with no ultrasound, 1 with second trimester ultrasound looking for anomalies, and 1 with first trimester ultrasound without looking for anomalies. And what was found? No women chose no ultrasound. There was 1 in 100 women who didn't want the moral risk of looking for anomalies, and they should be respected. And there are some women who don't want the moral risk. We shouldn't force ultrasound upon it, but the overwhelming majority of women want to know. And I want to emphasize that doesn't mean they must have an abortion if an anomaly is detected. There's good that can be obtained if an anomaly is found, even if abortion is not an option. And we've shown this in our population. Let's not waste time with this. But I want to present the other counterexample. A disturbing trend is shopping mall ultrasound, baby pictures. I hope that's not an issue in Louisville. And we take a stand, and we call it what it is, the medicalization of fetal imaging. Obstetric ultrasound is the single most important exam in pregnancy. The shopping mall ultrasound, baby pictures, is a misleading label. There's the lack of counseling that some women lead. Blanket prescription should not be done, please. I'm a capitalist. I support money-generating activities. There's nothing intrinsically wrong with this, but this needs to be done in a professional setting. Even Illich did a classic text years ago arguing against over-medicalization, and we support that, not in this case. Ultrasound belongs within medicine, not outside medicine. We support. Indeed, our unit gives women ultrasound pictures. There's nothing wrong with this, but it needs to be done in a medical setting. Forgive me if I've done rapidly. I thought the best way I could honor Dr. Cheng's memory is to give an overview, a broad-based overview of an important subject. I'm grateful to the family for the privilege of being here. Thank you so much, and I believe this was a person who lived and breathed ethical practice, not just in the abstract, but in the concrete. Thank you so much. Absolutely.
By the way, just to remind you, these will be on our Vision webpage in about 2 weeks. Soon thereafter, we actually now have an agreement with iTunes, so that it'll show up on iTunes University or Louisville Bioethics. Any questions?
Yes, please, sir.
Explain why viability is so important. Identification of being fetus in the patient has to do with the effect on the child's fetus to become. Who cares about viability?
Excellent question. The question is why viability is important. After viability, there's a social role. That for medicine, medicine has a duty to, how can I put this in simple terms? Prior to fetal viability, all of our technology, all of our skill can do nothing without the woman's body as a necessary condition. After viability, the woman's body is not a necessary condition. That's the nature of the distinction of viability in a simple term. In other words, that's why viability is the important distinction that it is. Yes, please.
I'm not sure how to phrase it, but in terms of considerations on abortion, is that it's society's responsibility to help care for the disabled and handicapped. But our society really doesn't. Then what?
I don't understand the question. Explain.
You say that when we consider abortion, one of the issues we have to take into consideration is the fact that society, it is the obligation, that in a world of justice, that it is a societal obligation to take care of the less fortunate, the handicapped, the disabled. But our society doesn't provide support for disabled children in terms of education and other special needs that they have. And so,
oh, I think in America we've taken giant steps forward. The question is that, well, the question is that does society really take care of handicapped children? And I'd say America's taken giant steps forward with the American with Disabilities Act. Wouldn't you agree with that?
definitely, but not there yet.
Oh, agreed. I agree. There's so much more that should be done, and physicians have obligations to push for that, which we do. I very much agree with you that there's more that should be done, but I think America, we can speak as Americans, I think much has been done, but there's still much more that can and should be done.
I guess what I'm asking is, from an ethical point of view, if one of your criteria hasn't been met, and I don't know if I did, if one of your criteria hasn't been met, can you then continue with that same argument?
Wait, what is, I believe there's, in what setting? But please make.
Well, specifically in the abortion setting. You're assuming that if a disabled child is born, that society will help take care of it. Many societies don't.
Well, I can only speak to America and Great Britain where this is an active argument. And in these countries there are the resources and there are tremendous supports for such children. In other words, to argue that is my colleagues in Great Britain, and this is where we've gotten into active disagreement, for doctors to argue that burden on society should be used as a criteria for abortion, I disagree strongly with them. Burden on society should not be used as a criteria for abortion. That's where I disagree with them strongly. I think they would agree with me and you that doctors have an obligation to argue for societal resources for the disabled. I don't think they would disagree with you or me on that point. I disagree with them that burden on society should be used as a criteria. Yes, sir.
I'm shocked with the fact that your specialty is biological force passages of ultrasound is fairly high. What is the specialty doing to improve the technology so that you don't have such a high ultrasound force passages?
Oh, okay, can I? Excellent question, excellent question. I showed this slide for historic purposes. Excellent question. Thank you. The question was that was very high false positive rates that I showed. Thank you for asking the question so I can clarify it. I show that slide for historic purposes. That slide is maybe 20 years old. And that slide was not from America, it was from another country. I assure you, these false positive rates do not exist in the United States at this time. If there is any good to the professional liability crisis, there would be appropriate professional liability for a false positive case for serious fetal anomalies. So I assure you, this does not go on today. I was using that slide to make a didactic point. Thank you so much for letting me clarify that misunderstanding. Thank you. Yes, sir.
On your previous slide, when you were discussing counseling a patient, you mentioned legal action. Can you go back to that slide?
Which legal action? Which?
It was, it was when you're counseling a patient on whether they should perform first procedure and you didn't mention something. Just when you're selecting this in legal action, I think it pertained to whether or not refused to do a procedure or not.
Okay.
If legal action could be taken against you or refusal to perform a various procedure.
You mean coercion? What was it, the coercion? Yeah. This is a very controversial issue. Fortunately, it rarely happens. The issue comes up, is it ever appropriate to coerce a woman to have a cesarean delivery? Was that?
That's part of it, yeah.
Okay, this is a big subject. It was, it's a controversial point. Some would argue it is never appropriate to coerce a woman to have a cesarean delivery. It's a violation of civil liberty and it's inappropriate. We would take a stand in extreme circumstances that it's the least worst option is that there is a place for coercion. For example, we put forward a case 15 years ago where a woman presented to us, one of our patients, who had what's called the placental abruption. This is where the placenta starts to separate, and she was at term. And there was the beginning of fetal distress, and the medically correct action, take my word for it, is an immediate cesarean delivery, both for the fetal condition, because the fetus could suffer brain damage and die. In the maternal condition, there's a buttressing issue. She could also get into hematologic problems. So it's a black and white medical decision. She refused. We said, why? She kept silent. I promise you, if we had gotten a psychiatry consult at the time, she would have been found competent. In a very narrow definition of competence, she was oriented. She was scared. She was very scared at the moment. We made a judgment at that moment that the least worst thing to do was to inform her we must do a cesarean delivery now. We got administrative consent. We did the cesarean. She thanked us. Afterwards, she and the baby did fine. This is a hotly controversial subject. I realize that the ethics committee is here, legal counsel. This is hotly controversial. I know George Addis, who's the commentator for the New England Journal, would say this is unconscionable. How could you do this? We would argue, we've written in the Hastings Center report our obstetric literature about this. We would argue strongly against it. We've made ethical arguments, the distinction between positive and negative rights. This patient isn't leaving the hospital. She is making a positive demand on us to do something that's unprofessional by any standard, to assist in causing a brain damaged or dead baby. I can't abrogate my fiduciary responsibility to her and the fetal patient, the soon-to-be-born child, in this setting. And this is not a win-win situation. You've got to pick the least worst alternative. We'd make an ethical argument. Administration supported of us this, and we decided in this very extreme situation, the least worst alternative is coercion. And just so you know, a few months ago we discussed it with legal counsel. If this same thing were to happen tonight on my service, we would do the same thing. Having said that, I want to be notified if anyone is thinking of doing this, because there have been infamous cases in obstetrics where obstetricians have pursued court orders and coercion for cases that shouldn't have been pursued. placenta previas that weren't there, fetal distress that didn't turn out to be fetal distress. So what I'm saying is coercion has a place for a prolapsed umbilical cord, a well-documented previa that I'm sure, going back to your point, that ultrasound, state-of-the-art ultrasound is sure that a placenta previa is there, placental abruption. With the highest medical certainty, yes, then I would pursue coercion in an emergency setting. And we would go forward is the least worst alternative, and I would deal with the civil libertarians after the fact. It's controversial. Some would disagree with me, and we would deal with it. There's liability with whatever you do with this. There's liability either way you do with it. Our lawyers would rather face this liability than we had an infamous case before I came to Cornell where the doctors acquiesced, and sure enough, a brain-damaged baby. There was a lawsuit because the doctors didn't do everything reasonable to pursue a cesarean. It's a very complicated matter, but the direct answer to your question, today in 2010, we would pursue coercion in extremely, extremely, extremely rare circumstances.
For the good of the fetus.
What's that?
For the good of the fetus. Yeah, never mind.
No, wait, no, it's much more than that. For the interests of the fetal patient, to preserve the integrity of the medical practice, to preserve the interests of obligations to the pregnant woman. We take the view that respect for maternal autonomy is not an absolute obligation. And I put this forward as a perfect case study, that an obligations approach to medical ethics is a superior approach than a rights-based approach to medical ethics. I take that view very clearly. If you put your feet in cement and talk about rights-based approach, it's going to obfuscate medical practice, not facilitate ethical medical practice. That's my view on this.
You're done. Thank you, sir.
Thank you.